we will dive into angina pectoris. This condition, often linked to chronic coronary disease and atherosclerosis, is a complex puzzle with a range of triggers and potential causes that we will explore. A primary cause of angina is the blockage of coronary arteries, courtesy of atherosclerosis. These blockages restrict blood flow to the heart muscle, resulting in chest pain or discomfort symptoms. But here's where it gets intriguing. Angina can also be triggered by coronary vasospasm. Picture this. Arteries suddenly constrict, either at the site of an atherosclerotic lesion or less commonly in seemingly healthy vessels. Now let's take a journey into the less common culprits of angina. We are talking about congenital abnormalities of coronary arteries, emboli causing blood flow obstructions, arteritis, or dissection. Any of these conditions can lead to insufficient blood supply to the heart muscle, ultimately setting the stage for angina. But hold on, here is a plot twist. Angina can make an entrance even when there is no apparent blockage in the coronary arteries. Picture a scenario where severe ventricular hypertrophy, severe aortic stenosis, or heightened metabolic demands come into play. These heightened demands might stem from conditions like hyperthyroidism, severe anemia, or paroxysmal tachycardias with rapid ventricular rates, and can all cause angina. And now, let's talk about one of the most mysterious forms of angina, syndrome X. This enigmatic phenomenon occurs when patients experience angina, yet their coronary arteries appear normal angiography with no other identifiable causes. It's a true medical puzzle. Syndrome X is believed to be tied to inadequate flow reserve within the heart's microvasculature. Diagnosing it can be quite a challenge, and treatment may not always offer a complete relief from symptoms. That being said, there is a silver lining. The prognosis for patients with syndrome X is generally favorable. Angina's association with physical activity is a key hallmark. It tends to ease when the patient rests. Interestingly, patients might prefer to stay upright rather than lie down, as this reduces the heart's workload. The triggers for angina can differ from one person to another and even from day to day. It can rear its head after a meal, during moments of excitement, or when the weather turns cold. And here is a curious twist. Angina can also strike at rest or during sleep, thanks to coronary artery spasms. People will describe waking up with angina. Now here's where it gets intriguing. Patients often don't describe angina as just pain. It can manifest as various sensations: tightness, squeezing, burning, pressing, choking, aching, bursting, and even feeling like gas. Picture someone clenching their fist over their chest or Levine sign. The location of the discomfort can be a puzzle and varies among individuals. For most patients, it's consistent, typically felt behind or slightly on the left of the midsternum. If it starts farther to the left or on the right, it often moves centrally beneath the sternum. But here's where it gets fascinating. Angina can radiate, sending discomfort to various areas. The left shoulder and upper arm are common targets. It might travel down the inner arm to the elbow, forearm, wrist, or even the fourth and the fifth fingers. It can also radiate to the right shoulder or arm, lower jaw, neck, or back. What's remarkable is that angina episodes are generally short-lived. If exertion triggers an attack and the patient rests promptly, it usually lasts less than 3 minutes. However, after a heavy meal or during moments of emotional distress, these attacks can persist for longer, typically around 15 to 20 minutes. Now here's a critical note. Attacks lasting more than 30 minutes are uncommon and should raise concerns about the possibility of acute coronary syndrome, including unstable angina, myocardial infarction, or any other diagnosis. Lastly, the diagnosis of angina pectoris can be supported if sublingual nitroglycerin consistently and promptly relieves an angina attack. However, it is not diagnostic, since esophageal spasms can also cause chest discomfort and can also be relieved by sublingual nitroglycerin. The patient's entire clinical picture and risk factors for coronary disease need to be examined. Now let's move on to the NYHA classification system, a crucial tool in assessing heart disease and its impact on a patient's physical activity. It's a way to categorize heart disease into different stages based on symptoms. Here is a breakdown. Class 1. Imagine a situation when there is no limitation to physical activity. Ordinary tasks and activities do not lead to undue fatigue, shortness of breath, or chest pain. It's a relatively comfortable state of affairs. Class 2. Now picture a slight limitation of physical activity. Everyday activities can trigger symptoms. You are not entirely restricted, but there is a noticeable impact on your routine. Class 3. Things take a marked turn here. You may be comfortable when resting, but as soon as you attempt anything active, symptoms kick in. It's a significant limitation on your physical activities. Class 4. This is when things get challenging. You find yourself unable to engage in any physical activity without discomfort, and symptoms start occurring at rest, making it quite restrictive. Now it's time to shift our focus to the signs that reveal themselves during the examination of patients with angina. When a patient has angina, their blood pressure can play tricks on us. It's not uncommon to witness a significant increase in both systolic and diastolic blood pressure, but sometimes we may encounter hypotension. This drop in blood pressure can be a red flag, especially when it accompanies bradycardia. When hypotension and bradycardia occur together, along with vasodilation, it can signal a phenomenon called the Bezold-Zeresh reflex. This is mediated through cardiac vagal afferents and originates from inhibitory mechanoreceptors in the left ventricle that are stimulated by stretch, chemical substances or drugs, which increases renin and vasopressin release and parasympathetic activity and inhibits sympathetic activity. Now, as we delve deeper into our examination, a keen cardiac assessment might unveil some intriguing signs. Picture this. We hear a gallop consistent with an S4 or an apical systolic murmur. What's causing this murmur, you ask? Papillary muscle dysfunction can lead to transient mitral regurgitation. Here is the kicker. These findings may only rear their head during the actual angina episode, adding a layer of complexity to our diagnosis. But wait, there's more. Patients with angina can throw us curveballs in the form of irregular heart rhythms. These rhythms can be either supraventricular or ventricular, and they might either trigger angina or be a result of ischemia. Now, here is a crucial point. We need to look for signs of underlying conditions that can accompany atherosclerotic heart disease, which is often the root cause of angina. These conditions are like silent partners, and they include diabetes mellitus, hyperlipidemia, hypertension, thyroid disorders, and peripheral artery disease. But our examination doesn't stop there. We also need to assess for heart conditions that mimic or contribute to angina, but aren't necessarily linked to atherosclerotic heart disease. These include aortic stenosis, hypertrophic cardiomyopathy, and mitral valve prolapse. When it comes to lab tests for chronic angina, there are some standard tests such as troponin and CKMB. First and foremost, those initial tests are crucial as they help us rule out acute cardiac events and provide vital information about myocardial damage. But we need to go beyond them into the factors that contribute to myocardial ischemia. Take anemia for example. It can reduce the blood's ability to carry oxygen, making angina symptoms worse. So we make it a point to assess hemoglobin levels. But that's not all. We also need to look for risk factors that can increase the likelihood of coronary artery disease. Two key players in this quest are hyperlipidemia and diabetes mellitus. We keep a close eye on lipid profiles and blood glucose levels to spot these risk factors and treat them before they can cause further trouble. While these tests are important, routine blood workup does not have any significant role in diagnosis of chronic angina. The diagnosis relies more on patient's history and clinical signs. Now when we look at the resting EKG of patients with angina, it might surprise you to know that it often appears completely normal. But don't let that fool you, because sometimes there are telltale signs hiding in plain sight. These can include hints of a previous myocardial infarction, non-specific ST wave changes, or even signs of left ventricular hypertrophy. But here's where it gets truly interesting. During episodes of angina or even during episodes of asymptomatic ischemia, we often witness a characteristic change on the EKG. Imagine this, the EKG tracing starts showing horizontal or downsloping ST segment depression. It's a fingerprint of angina. What's crucial to understand is that this ST segment depression tends to go away once the ischemia resolves, either on its own or with appropriate treatment. And that's not all. We might also spot T-wave flattening or inversion during these episodes, adding another layer to our diagnostic toolkit. But wait, there's more to the EKG story in angina. Although less frequent, there are instances where we might see transient ST segment elevation on the EKG during anginal episodes. Now, this finding is significant because it suggests severe transmural ischemia. It's a red flag signaling that something serious is happening. This transient ST segment elevation can occur due to coronary artery occlusion, but it can also make an appearance in cases of coronary spasms. Now, let's dive into a critical aspect of diagnosing coronary artery disease, and that's the pretest probability assessment. This step is the foundation upon which we build our diagnostic approach, and it's a comprehensive process that considers several key factors. First and foremost, we start with a detailed patient history. We want to know everything about the patient's symptoms, what they are like, when they occur, what triggers them, and what brings relief. This is the first piece of the puzzle. Next, we turn our attention to the physical examination. We check vital signs like blood pressure, listen to cardiac sounds, and keep an eye out for any associated signs that might provide additional clues. Lab and EKG findings then come into play, providing us with valuable insights into the patient's cardiac health. These findings help us refine our pretest probability assessment. Age and gender also play a role. They influence the risk profile for coronary artery disease. For instance, as we age, our risk generally goes up, and there can be gender specific differences in risk, with men generally being higher risk than women. Using this information, we can calculate the pretest probability of coronary artery disease, which helps us select the most appropriate diagnostic test. Patients with a low to intermediate pretest probability for CAD usually undergo non-invasive testing using either exercise or pharmacological stress tests. When the pretest probability is high, we often refer patients for cardiac catheterization. In recent years, a game changer has emerged in the form of coronary CT angiography. The PROMISE trial compared this approach to functional testing. Both strategies led to similar rate of cardiovascular events, but the CT angiography arm was associated with fewer patients without obstructive disease undergoing cardiac catheterization. This means it helps reduce unnecessary invasive procedures. Now, exercise EKG testing is often combined with imaging studies such as nuclear or echocardiography to provide us with a more comprehensive understanding of the heart's condition. But here is the thing. In a low-risk patients without baseline ST segment abnormalities, or when we don't need precise anatomic localization, exercise EKG is typically our go-to initial procedure. Why, you ask? Well, it's influenced by considerations of cost, convenience, and the wealth of long-standing prognostic data associated with this test. So how does this test work? We can conduct it on a motorized treadmill or a bicycle ergometer with the various exercise protocols available. The Bruce protocol is the most common, where we gradually increase treadmill speed and elevation every 3 minutes until the patient reaches their limit due to symptoms or reaches their target heart rate. During the test, we continuously monitor at least 2 EKG leads to catch any changes. But like any medical procedure, it's not without risk. The estimated risk of a myocardial infarction or death is approximately 1 per 1000 tests. Patients experiencing pain at rest or with minimal activity are at higher risk and should not undergo this test. Many traditional exclusions such as recent myocardial infarction or heart failure are no longer used if the patient is stable and ambulatory. That being said, symptomatic aortic stenosis remains a relative contraindication. Exercise stress testing serves several important purposes such as confirming the diagnosis of angina, determining the severity of activity limitation due to angina, assessing the prognosis of patients with known coronary artery disease, and evaluating response to therapy. It's important to note that exercise testing for asymptomatic individuals is typically reserved for those whose occupation put them or others at special risk, such as airline pilots or patients who are undergoing perioperative testing. A positive test is usually defined as the presence of 1 mm or 0.1 mV horizontal or downsloping ST segment depression measured 80 milliseconds after the J point. This criteria help us identify approximately 60 to 80% of patients with significant coronary artery disease. However, here's the catch. 10 to 30% of patients without significant coronary artery disease might also have a positive test, leading to false positives. We gather additional information from various factors like the timing and duration of EKG changes, their magnitude and pattern, changes in blood pressure and heart rate, exercise duration, and the presence of associated symptoms. Patients who exhibit more severe ST segment depression at low workloads or heart rates, especially with limited exercise duration or a rise in blood pressure, may have severe coronary artery disease and a poorer prognosis, warranting further evaluation. On the flip side, less impressive positive test results in asymptomatic patients are often false positives. Therefore, exercise testing results that do not align with clinical suspicion should be confirmed through stress imaging or other complementary tests. Now, when we talk about radionuclide imaging, we are dealing with some special isotopes, including thallium, technetium, sesame B, and tetraphosphine. But why do we turn to myocardial perfusion scintigraphy? Well, it serves several essential purposes in clinical practice. It is useful when the resting EKG presents challenges for interpreting an exercise EKG. Think of situations like left bundle branch block, baseline STT changes, or low voltage. It can serve as confirmatory test if the results of the exercise EKG do not fit with the clinical impression, such as a positive test result in an asymptomatic patient. It can also help us pinpoint the specific region of ischemia in myocardium, distinguish between ischemic and infarcted myocardium, assess the completeness of revascularization, and serve as a prognostic indicator in patients with known coronary artery disease. Now let's understand how this test works. A radio tracer is injected either during exercise or through pharmacologically induced coronary vasodilation. The magic happens as we capture scintigraphic images, and any defects that pop up can indicate areas of hypoperfusion. These areas may present either ischemia or scar tissue. And here's where it gets fascinating. If the myocardium is viable, these defects tend to fill in or reverse over time or during a resting scintigram. This tells us that the ischemia is reversible. Stress imaging turns a positive in a significant percentage of patients with anatomically significant coronary artery disease and a smaller proportion of those without it. However, it's important to remember that certain conditions such as infiltrative diseases or cardiomyopathies can produce resting or persistent perfusion defects, adding a layer of complexity to the interpretation. But that's not all. There is another player in the field of radionuclide imaging, radionuclide angiography, also known as a MUGA scan. This technique employs radionuclide tracer to visualize the left ventricle and measure parameters like ejection fraction and wall motion. Resting abnormalities usually hint at infarction, while exercise-induced abnormalities often indicate stress-induced ischemia. It's a versatile tool not just for diagnosing coronary artery disease, but also monitoring patients exposed to cardiotoxic therapies like certain chemotherapeutic agents. And last but not least, we have stress echocardiography. This involves using echocardiograms during or immediately after exercise to detect exercise-induced segmental wall motion abnormalities, which can be a sign of ischemia. While exercise is the preferred stressor, pharmacologic stress with a high-dose dobutamine can be an alternative in certain cases, giving us valuable information about the heart's function. Now let's move on to positron emission tomography. PET uses positron emitting agents to create images that reveal the perfusion or metabolism of myocardial tissue. It is valuable because of its ability to distinguish between transiently dysfunctional or stunned myocardium and scar tissue. While PET offers high quality images, it's often compared to SPECT imaging, which is a more budget friendly alternative that can still yield acceptable results. Next, we step into the world of CT scanning, a versatile tool that can capture images of heart and its coronary arteries. With the use of contrast medium and advanced multi-slice technology like the 64 slice and beyond, CT scans provide detailed visuals of coronary vessels. This technology is especially valuable when it comes to ruling out significant coronary artery disease non-invasively. It also offers an advantage in terms of lower radiation exposure when compared to radionuclide SPECT imaging. There is a novel technique known as CT angiography with non-invasive functional assessment of coronary stenosis or CT-FFR, which can reduce the number of patients without coronary artery disease requiring invasive angiography. It is endorsed in the 2021 ACC/AHA guidelines for the evaluation and diagnosis of chest pain. Now let's explore electron beam CT, also known as coronary calcium scoring. This method quantifies coronary artery calcification, which is closely correlated with erythematous plaque. It's highly sensitive but less specific for obstructive coronary disease. While it can stratify patients into lower and higher risk groups, its precise role in managing asymptomatic patients remain a subject of ongoing research. Traditionally, it hasn't been used in symptomatic patients. According to the American Heart Association, it's not recommended for patients at low or high risk for obstructive coronary artery disease, but may be considered for clinically selected intermediate risk patients. Lastly, we have cardiac MRI, a remarkable tool that uses gadolinium contrast to provide high resolution images of the heart and great vessels, all without radiation exposure or the use of iodinated contrast media. Cardiac MRI is incredibly versatile, helping us to assess pericardial disease, neoplastic process, myocardial thickness, chamber size, congenital heart defects, and even aortic dissection. It can also evaluate myocardial perfusion under pharmacologic stress using agents like dobutamine or adenosine. One of its most significant clinical uses is identifying myocardial fibrosis, which can result from myocardial infarction or infiltration. This enables us to evaluate myocardial viability and diagnose conditions like infiltrative cardiomyopathies. However, it's crucial to be aware of a rare but serious complication associated with gadolinium-based contrast agents, nephrogenic systemic fibrosis in patients with severe kidney disease. Now you might wonder, can Holter monitors help us detect ischemia? Well, the truth is, they are not typically the tool for that job. Their primary role is in the detection of arrhythmias. Now let's go back to ischemia for a moment. In patients with coronary artery disease, Holters can indeed capture episodes of ST segment depression, which often signals ischemia even when the patient feels just fine. Now, many cases, these silent episodes can be more frequent than the symptomatic ones. Silent ischemia usually happens in patients who already have other evidence of ischemia, like clinical symptoms or positive stress test. So the role of a Holter is somewhat limited. Now, where these recorders truly shine is in the world of arrhythmias. They continuously record the heart's electrical activity over a period of time. This allows us to identify various arrhythmias, including atrial fibrillation, ventricular arrhythmias, and other rhythms. Imagine a procedure that allows us to see the intricate network of coronary arteries, all with the help of contrast dye and X-ray imaging. It's no wonder that coronary angiography is considered the gold standard for diagnosing coronary artery disease because of its precision and accuracy. But when do we turn to coronary angiography? It's recommended in specific clinical scenarios where CAD is strongly suspected or when we are considering revascularization procedure like percutaneous transluminal coronary angioplasty or coronary artery bypass surgery. Let's take a look at these scenarios. First, we have cases of life-limiting stable angina despite optimal medical management. Then there are high-risk clinical presentations like unstable angina or post-infarction angina or non-invasive tests that strongly suggest significant CAD. Coronary angiography also comes into play when we are dealing with concomitant aortic valve disease and angina. It helps us pinpoint the cause of angina in such complex cases. In asymptomatic older patients undergoing valve surgery, coronary angiography can be a valuable addition assessing for concomitant bypass if needed. For patients experiencing a recurrence of symptoms after coronary revascularization, it's essential to assess the status of grafts or native vessels. In cases of heart failure with suspected surgically correctable lesions, coronary angiography is a crucial step in the diagnostic process. For survivors of cardiac arrest or those with life-threatening arrhythmias where CAD may be a correctable cause, it's necessary. In emergency situations such as when primary percutaneous coronary intervention or PCI is intended for a patient with suspected myocardial infarction, it's an urgent diagnostic tool. Now, during coronary angiography, we consider a narrowing of more than 50% of the luminal diameter as significant, both in terms of hemodynamics and clinical implications. However, most lesions that cause ischemia are associated with a more substantial narrowing, often exceeding 70%. For patients with strongly positive exercise EKGs or scintigraphic images, there is a higher likelihood of 3-vessel or left main disease. But we don't stop there. We have additional tools in our arsenal. Intravascular ultrasound helps us assess the results of angioplasty or stenting, giving us a closer look at the coronary landscape. It's particularly useful for evaluating ostial left main lesions and coronary dissections. And then there is the fractional flow reserve or FFR, a vital tool during coronary angiography. It involves measuring the pressure difference across a coronary lesion after inducing hyperemia. Decisions about revascularization based on abnormal FFR have been shown to improve clinical outcomes compared to relying solely on angiographic appearance. As a bonus, during coronary angiography, we often perform left ventricular angiography, which provides crucial information about global and regional left ventricular function as well as the presence of mitral regurgitation. Left ventricle function is a significant factor in determining the prognosis in CAD. Now let's continue our exploration of angina management and the factors that can aggravate or alleviate its symptoms. First up, we have hypertension. Managing blood pressure is crucial in keeping angina at bay. Next on the list is left ventricular failure. Tackling heart failure is a key part of effective angina management. Arrhythmias can also be troublemakers when it comes to angina. Balancing the heart's rhythm is essential. Intense physical activity, cold temperatures, and emotional stress are also triggers for angina. Identifying these triggers and addressing them is a vital part of the puzzle. Imagine a medication that can swiftly reduce the discomfort of angina, often within just 1 to 2 minutes. Nitroglycerine is its name, and it belongs to a remarkable class of drugs called nitrates, which have a range of beneficial effects on the cardiovascular system. Let's talk about how nitrates work their magic. First, they decrease venous tone, decreasing the preload or the amount of blood returning to the heart, which reduces the heart's workload. They also decrease arteriolar tone, decreasing the afterload or the resistance that the heart faces when pumping the blood out to the body, which also reduces the workload of the heart. When an angina attack strikes, it's essential to reach for sublingual nitroglycerine promptly. The patient places one tablet under their tongue. If the pain doesn't ease or improve after 5 minutes, it's time to seek immediate medical attention. That's because persistent or unresponsive pain, especially lasting more than 20 minutes, could be a sign of a more serious issue like an evolving myocardial infarction. Nitroglycerine isn't just available in tablet form. It also comes as a buccal spray delivered in a metered dose. This spray offers some advantages, particularly for patients who might struggle with tablets. It is more stable than tablets, ensuring consistent dosing. We also have longer-acting nitrates that offer sustained relief. These include isosorbide dinitrate, isosorbide mononitrate, nitroglycerine ointment, and transdermal nitroglycerine patches. Now, a word of caution with those patches. They should be removed after 12 to 14 hours of use, allowing for a 10 to 12 hour patch-free interval each day. One challenge with long-acting nitrate therapy is the development of tolerance called tachyphylaxis, which is the body getting used to the medication. We can minimize this by ensuring at least 8 hours of a nitrate-free period each day. When it comes to nitrate therapy, it's important to be aware of potential side effects, which can include headache, nausea, lightheadedness, and hypotension. You also need to keep in mind that phosphodiesterase inhibitors, commonly used for erectile dysfunction, interact with nitrates and should not be taken within 24 hours of a nitrate dose due to the risk of significant hypotension. Now let's dive into a remarkable class of medications that truly stand out in the realm of angina management. Beta blockers. They are very helpful in treating angina, but based on the newest guidelines from the ACC/AHA in 2023, they are not recommended for use in chronic coronary disease unless there is a separate indication, such as an ejection fraction less than 50%, a previous myocardial infarction, arrhythmias, or hypertension. Beta blockers are the unsung heroes of angina treatment since they alleviate symptoms and also prolong life in patients who have had a myocardial infarction. Now, when it comes to picking the right beta blocker, it's essential to know that not all of them are created equally. Some beta blockers like pindolol have intrinsic sympathomimetic activity which isn't always desirable. It can actually worsen angina in certain patients and hasn't shown the same effectiveness in preventing secondary cardiac events. Despite having differences in characteristics like cardioselectivity, vasodilation effects, and lipid solubility, all beta blockers seem to work equally well in treating angina. So the choice of which specific beta blocker to use might come down to individual patient factors and preferences. But, and this is a big but, there are some red flags to watch out for. If a patient has severe bronchospastic disease, certain beta blockers could make things worse. And if there are bradyarrhythmias or decompensated heart failure in the picture, consider avoiding beta blockers for now. Now let's move on to calcium channel blockers or CCBs. It's important to note that they have a different story compared to beta blockers, especially when it comes to their impact on survival after an MI. Unlike beta blockers, calcium channel blockers haven't shown the same life-saving benefits following an MI. In fact, in some cases, they have been associated with an increase in ischemic events and even mortality. This is particularly relevant to certain calcium channel blockers known as dihydropyridines such as nifedipine. This risk seems to be more pronounced in patients with heart failure or significant left ventricular dysfunction. Given these uncertainties and the lack of a clear benefit in terms of patient outcomes, calcium channel blockers are often reserved as the third line of defense in post-MI patients. In patients with heart failure, calcium channel blockers except for amlodipine are not advised. Amlodipine can be used since it was found to be safe for the treatment of hypertension in heart failure patients in the PRAISE-2 trial. Let's explore the medication known as ranolazine, specifically designed to address the challenges of chronic angina. Ranolazine reduces the late sodium current, which in turn helps alleviate the calcium overload within the heart muscle. Numerous clinical trials consistently demonstrate ranolazine's efficacy in extending exercise duration and delaying the onset of angina. Whether used independently or in conjunction with traditional anti-anginal therapies, it consistently delivers positive results. Ranolazine doesn't significantly affect heart rate or blood pressure, and this feature is crucial for patients who cannot tolerate much fluctuation in heart rate or blood pressure. Ranolazine is compatible with medication used to treat erectile dysfunction, avoiding potential interactions in this regard. There are limitations to consider. Ranolazine should be avoided by individuals with an existing QT prolongation as it may exacerbate this condition and should not be taken by individuals who are taking medication known to prolong the QT interval such as antiarrhythmics or cytochrome inhibitors. Despite its potential to prolong the QT interval, ranolazine has demonstrated a lower rate of ventricular arrhythmias when used following acute coronary syndrome as observed in the Merlin trial. Moreover, it has shown promise in reducing the incidence of atrial fibrillation and has contributed to a slight decrease in HbA1c levels. It's important to note that ranolazine should be used cautiously in patients with significant liver or kidney disease due to potential complications. Lastly, ranolazine is not intended for the treatment of acute anginal episodes but rather serves as a long-term therapy for managing chronic angina. Now let's move on to ivabradine, a medication with a unique mechanism of action that specifically targets heart rate reduction. While many cardiac medications have broader effects, ivabradine is precision engineered to slow down the heart rate. Research has revealed ivabradine's effectiveness in alleviating angina symptoms among patients with chronic stable angina. In Europe, it has gained approval and is well regarded in the management of angina. However, an essential study called the Signify trial raised interesting findings. This trial examined ivabradine's use in patients who had chronic coronary disease but not heart failure. Surprisingly, the results showed that there was no significant overall difference in clinical outcomes. Even more striking was the concern that for patients experiencing significant angina, there might have been adverse effects related to cardiovascular death and myocardial infarction outcomes. In the realm of angina management, it's important to recognize that not all patients respond in the same way to a particular class of anti-anginal medication. When one type of medication falls short or doesn't provide the relief needed, a thoughtful approach is necessary. According to the guidelines, the initial step is typically to begin treatment with a beta blocker. These medications have a well-established track record when it comes to managing angina and are often the first choice. However, if a patient does not experience the desired relief with beta blockers, there is no need to lose hope. The guidelines provide a roadmap for the next steps. They recommend considering alternative options such as calcium channel blockers, long-acting nitrates, or ranolazine. This structured approach ensures that patients receive the most effective treatment tailored to their specific needs. Now let's dive into the fascinating world of antiplatelet medications and their role in managing vascular disease. These medications play a crucial role in preventing serious cardiovascular events. Now let's explore some key insights from recent studies and clinical guidelines. First and foremost, aspirin at a low dose of 81 mg is often prescribed for patients with angina as well as those with stable and unstable vascular disease. It's a go-to choice unless there are contraindications. Aspirin has a proven track record in reducing cardiovascular events. But what about those who cannot tolerate aspirin or need an alternative? Enter clopidogrel, taken orally at 75 mg daily. This medication has shown its effectiveness in reducing vascular events and can be a suitable substitute for aspirin. In fact, it's also used alongside aspirin in patients with acute coronary syndromes. However, here is an interesting twist to this story. Some trials, like the Charisma trial, did not find a significant reduction in the risk of heart attack, stroke, or cardiovascular death when combining clopidogrel with aspirin. Instead, they observed an increase in bleeding. But don't just write off this combination just yet. In certain scenarios, it may be considered, especially for high-risk patients with established coronary artery disease, as highlighted in the dual antiplatelet therapy trial, also known as DAPT trial. Prolonged use of clopidogrel and aspirin may prove beneficial, particularly for patients who have undergone percutaneous stenting with drug-eluting stents and have a low risk of bleeding. Now let's talk about ticagrelor. This medication has shown remarkable efficacy in reducing cardiovascular events, especially in patients with acute coronary syndromes. Moreover, in patients with a prior heart attack, long-term treatment with ticagrelor combined with aspirin outperforms aspirin alone in reducing cardiovascular events. But when it comes to peripheral artery disease, ticagrelor monotherapy did not show a significant reduction in cardiovascular events when compared to clopidogrel. Moving on to vorapixor, an inhibitor of the protease activated receptor 1. It has demonstrated its ability to reduce cardiovascular events in patients with stable atherosclerosis who have a history of heart attacks or peripheral artery disease. However, it is important to note that vorapixor is not suitable for patients with a history of stroke or transient ischemic attack due to an increased risk of intracranial hemorrhage. Last but not least, let's talk about rivaroxaban, a direct factor 10A inhibitor. When combined with low-dose aspirin, it has been shown to reduce cardiovascular events, including cardiovascular death, heart attacks, or strokes compared to aspirin alone. This option is approved and provides an additional choice for patients. In the world of guidelines, it's recommended that patients who have had a recent heart attack within 1 year or recent stenting within 6 months should be treated with dual antiplatelet therapy, which consists of aspirin and either clopidogrel or ticagrelor. For those at high ischemic risk, such as individuals with multivessel coronary artery disease or polyvascular disease, and with low bleeding risk, prolonged dual antiplatelet therapy for more than 1 year is advised. Statins are strongly recommended for all patients with coronary disease regardless of their initial LDL cholesterol levels. Their primary objective is to significantly reduce the risk of heart attacks and ischemic strokes. For patients aged 75 or younger, we suggest the use of high-intensity statin therapy. This approach involves using statins at higher doses to lower cholesterol levels more effectively. For individuals at very high risk, we adopt an even more aggressive strategy. This includes combining maximally tolerated statin therapy with the medication ezetimibe. We take this approach because in specific situations where LDL cholesterol levels remain elevated or non-HDL cholesterol levels are high, we need a comprehensive strategy to address the risk. Now let's take a moment to demystify PCSK9 inhibitors. These medications have garnered attention for their ability to manage cholesterol levels effectively. But how do they work? Imagine LDL cholesterol as the villain in our bloodstream and our liver cells as the heroes. Liver cells have specialized receptors called LDL receptors on their surfaces. These receptors attach to LDL cholesterol particles and remove them from the bloodstream. This is where PCSK9 comes into play, a protein produced in the liver. PCSK9's primary role is to regulate these LDL receptors. When PCSK9 binds to an LDL receptor, it promotes receptors degradation and inhibits its return to the cell surface. As a result, fewer receptors are available to clear LDL cholesterol from the bloodstream. PCSK9 inhibitors are monoclonal antibodies that block the action of PCSK9. These medications prevent it from binding to LDL receptors, which results in an increased number of LDL receptors on the surface of liver cells. LDL cholesterol is removed from the bloodstream more efficiently as the enhanced receptor facilitates its clearance. Eventually, the cholesterol is processed and excreted from the body. Now let's shift our focus to lifestyle changes such as regular exercise, smoking cessation, and weight management. Lifestyle adjustments are pivotal in managing coronary disease, particularly for patients with metabolic syndrome or those at risk of diabetes. Speaking of diabetes, there is an ongoing debate about the ideal blood sugar target for patients with both diabetes and cardiovascular disease. According to the advanced trial, tight blood sugar control, which is defined as an HbA1c of 6.5% or less, had benefits. However, the ACCORD trial found out that an aggressive blood sugar level goal defined as HbA1c of 6% or less in patients with both diabetes and coronary disease was linked to increased mortality. This risk was especially pronounced in those with a history of severe hypoglycemia, long-standing diabetes, and advanced vascular disease. The newest ACC/AHA guidelines also recommend the use of SGLT2 inhibitors and GLP-1 receptor agonists to reduce the risk of cardiovascular events in patients with type 2 diabetes and patients with heart failure. Shifting our attention to blood pressure management, the ACCORD trial showed an aggressive blood pressure goal with systolic blood pressure less than 120 mmHg did not significantly reduce CAD events but did reduce the risk of stroke. The SPRINT trial, which did not include diabetic patients, showed that aiming for a systolic blood pressure less than 120 mmHg did reduce cardiovascular events and decrease mortality compared to the group that had a goal blood pressure of less than 140 mmHg. It is important to keep in mind that there was a slight increase in adverse events in the group with the aggressive blood pressure goal. So what's the takeaway from all this? The American Heart Association has recommended defining hypertension at the 130 mmHg level. For the management of hypertension, our first line medications are ACE inhibitors and angiotensin II receptor blockers. Now let's move on to revascularization in the management of coronary artery disease. It's very important to understand when and for whom these procedures are recommended based on current guidelines and clinical evidence. The patients in whom revascularization is appropriate are patients with unacceptable symptoms despite optimal medical therapy, patients with left main coronary artery stenosis greater than 50% regardless of symptoms, patients with triple vessel disease who also have left ventricular dysfunction or ejection fraction less than 50%, or a history of previous transmural myocardial infarction, patient with unstable angina who even after achieving symptom control with medical therapy still show signs of ischemia on exercise testing or monitoring, and post-myocardial infarction patients who experience ongoing angina or demonstrate severe ischemia on non-invasive testing. The COURAGE trial showed that in patients with chronic angina and coronary artery disease that is suitable for percutaneous coronary intervention, performing PCI on top of rigorous guideline-directed medical therapy did not improve mortality beyond medical therapy alone. In the long term, it provided only moderate symptomatic improvement. For patients with mild to moderate CAD and limited symptoms, revascularization might not significantly improve their functional status or quality of life. For those with more significant disease such as two-vessel disease paired with left ventricular dysfunction, critical lesions defined as greater than 90% stenosis, especially in proximal left anterior descending artery, or clear physiological evidence of severe ischemia, revascularization becomes much more important. Recent studies have examined the role of PCI in patients with ischemic cardiomyopathy with ejection fraction less than 35% and myocardial viability. These studies have revealed that when compared to optimal medical therapy alone, PCI does not improve mortality, the rate of hospitalization for heart failure, or ejection fraction. The ischemia trial, which looked at patients with moderate to severe ischemia on stress testing, concluded that coronary angiography and revascularization did not reduce the risk of cardiovascular death, myocardial infarction, hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest when coupled with optimal medical therapy for preventing cardiovascular events. Now, when we talk about PCI, it's essential to address potential complications. One of the major early concerns is intimal dissection. This complication is quite rare, especially when coronary stenting is involved. To enhance outcomes, we often use intravenous platelet glycoprotein 2b3A inhibitors, and the use of intracoronary stents has markedly improved angiographic results, particularly in complex cases. After undergoing PCI, close monitoring is crucial, and this involves measuring specific biomarkers like CKMB and troponin levels. Defining periprocedural infarction has been a subject of debate, with many experts advocating for a comprehensive clinical definition that takes into account enzyme level, angiographic finding, and electrocardiographic evidence. One significant challenge associated with PCI has been the issue of restenosis. The introduction of drug-eluting stents has made a remarkable difference, reducing restenosis rate to less than 10% in the first 6 months, in contrast to high rates with bare metal stents or no stents at all. In cases of instant restenosis, repeat PCI with a drug-eluting stent or in rare cases, brachytherapy can be considered. Extensive research has shown that even for patients with moderate anginal symptoms and positive stress tests, PCI does not provide additional benefits over medical therapy in terms of reducing death or the risk of heart attacks. While PCI is effective at relieving angina, it's noteworthy that most patients in the medical therapy group also experience symptom improvement. Moreover, PCI has not proven superior to optimal medical therapy in terms of exercise time in patients with one vessel coronary disease. Therefore, the initial strategy may lean towards aggressive lipid lowering and anti-anginal therapy with PCI reserved for patients with significant and refractory symptoms or those unable to tolerate prescribed medications. Now, when it comes to comparing PCI with drug-eluting stents to coronary artery bypass grafting in patients with multivessel disease, the results are interesting. Over follow-up periods of 1 to 3 years, mortality and heart attack rates appear comparable, although repeat procedures are more frequent after PCI. It's important to note that stroke rates tend to be higher with CABG. The choice between these revascularization procedures may depend on coronary anatomy and patient's preference, but it's essential to remember that these findings may not apply universally to all patients with multivessel disease. For individuals with diabetes and multivessel coronary disease, the FREEDOM trial has shown that CABG surgery is superior to PCI in terms of reducing death, heart attacks, and strokes. CABG can be performed with remarkable success, boasting a low mortality rate of 1 to 3% in otherwise healthy patients with preserved cardiac function. However, it's crucial to understand that as patients get older or if they have had prior CABG surgeries, mortality rate tends to increase ranging from 4% to 8%. Now, one of the critical factors that influence the long-term success of CABG is the choice of grafts. Grafts that utilize one or both internal memory arteries, typically directed towards the left anterior descending artery or its branches, tend to offer the best long-term patency and blood flow. Additionally, segments of the saphenous vein or the radial artery can be used to bridge between the aorta and the coronary arteries distal to obstructions. Patient selection is another pivotal element in determining CABG outcomes. Patients with left ventricular function less than 35% or those who require additional procedures such as valve replacement face increased operative mortality. Similarly, individuals over the age of 70, those undergoing repeat procedures, individuals with significant non-cardiac diseases, especially chronic kidney disease and diabetes, or those in overall poor health also carry a higher risk of operative mortality and complications. Early graft patency rates are actually quite promising, hovering at around 85% to 90%, and they get even better when we are talking about internal memory grafts. These early outcomes are encouraging and indicate that the grafts are successfully allowing blood to flow to the heart muscle. But here is where it gets interesting. Subsequent graft closure rates are approximately 4% each year. Early graft failure often goes hand in hand with vessels that have poor distal flow, while late closure is more commonly seen in patients who continue to smoke or have untreated hyperlipidemia. This highlights the importance of lifestyle changes and the medical management in maintaining graft patency. So, how do we keep these grafts open? Well, antiplatelet therapy with aspirin has been proven to improve graft patency rates. Smoking cessation is an absolute must, as is aggressive treatment of hyperlipidemia, particularly with statin medications. Now, let's talk about the possibility of repeat revascularization. Sometimes, despite our best efforts, patient may experience recurrent symptoms due to progressive disease in their native vessels or graft occlusions. In such cases, a repeat revascularization procedure might be necessary. It's important to note that reoperation can be technically challenging and may have lower success rates than the initial CABG procedure. Now, why is it that PCI, which involves stenting, is often preferred by both patients and clinicians? Well, there are several factors at play. Firstly, PCI is often seen as a more cost-effective option compared to CABG, and it usually leads to shorter hospital stays. Secondly, there is a prevailing notion that CABG is a procedure best reserved for later stages. Lastly, many patients gravitate towards the less invasive nature of PCI, which is not a surgery and involves a shorter recovery period. These arguments tend to make PCI the go-to procedure for revascularizing symptomatic single vessel disease, and sometimes even two vessel disease. However, the waters get muddier when we are dealing with multi-vessel disease. It is difficult to clearly demonstrate an advantage of either PCI or cabbage in most cases. However, cabbage is preferred in patients with left main lesions, three vessel disease, and left ventricular dysfunction. Let's move to our next segment, AIM IQ, the MCQ challenge. Here we review 5 multiple choice questions to evaluate your grasp of the concepts. So let's get started. A 65-year-old male presents with recurrent episodes of chest pain. He describes the pain as a heaviness in his chest that typically occurs with exertion and is relieved by rest. He has a history of hypertension and is a former heavy smoker. Physical examination reveals no abnormal findings. An EKG shows no significant changes. CBC and CMP are unremarkable. Urine drug screen is negative. Which of the following is the most likely pathophysiological mechanism underlying this patient's chest pain? A. Coronary artery atherosclerosis causing luminal narrowing. B. Spontaneous coronary artery spasm. C. Aortic stenosis leading to left ventricular hypertrophy. Or D. Extremely severe anemia. Let's pause here while you answer the question. The correct answer is A. Coronary artery atherosclerosis causing luminal narrowing. This patient's recurrent episodes of chest pain occurring with exertion and relieved by rest are highly suggestive of angina pectoris. Angina is chest pain or discomfort that occurs when the myocardium does not receive enough blood and oxygen due to an imbalance between myocardial oxygen supply and demand. Coronary artery atherosclerosis causing luminal narrowing is a common cause of angina. Atherosclerosis can lead to luminal narrowing of the coronary arteries, limiting blood flow and oxygen delivery to the myocardium, especially during increased demand. While coronary artery spasms can cause angina, the patient's symptoms are more consistent with exertional angina, which is typically associated with atherosclerosis. Spontaneous spasm is less likely in this context. Severe aortic stenosis can lead to left ventricular hypertrophy and increased myocardial oxygen demand. Left ventricular hypertrophy can contribute to angina by increasing oxygen demand, but the most common cause of angina in patients with left ventricular hypertrophy due to aortic stenosis is subendocardial ischemia. Also, the patient's physical examination was unremarkable. Severe anemia can reduce the oxygen carrying capacity of the blood, but it is a less common cause of angina by itself. In patients with moderate coronary artery obstruction, severe anemia may lower the threshold for ischemia, but it is not the primary mechanism in this patient. Also, CBC is unremarkable. A 55-year-old male presents to the emergency department with severe chest pain that started at rest and has been ongoing for the past 30 minutes. He describes the pain as a crushing sensation in the center of his chest radiating to his left arm associated with shortness of breath, diaphoresis and nausea. His past medical history includes hypertension and a 20-pack year smoking history. On physical examination, he is diaphoretic, appears distressed, and his blood pressure is 160 by 90 mmHg, heart rate is 110 beats per minute, respiratory rate is 20 breaths per minute, and oxygen saturation is 96% on room air. An EKG shows ST segment elevation in the anterior precordial leads. Which of the following best explains the pathophysiology of this patient's condition? A. Worsening cardiac contractility due to acute on chronic heart failure. B. Acute rupture of an atherosclerotic plaque with thrombus formation. C. Hypercoagulability and hypofibrinolysis due to diabetes mellitus. Or D. Fatty acid oxidation impairment leading to intracellular pH reduction. Now let's pause here while you answer the question. This patient is presenting with an acute myocardial infarction characterized by severe chest pain, diaphoresis, pain radiating to the left arm, and EKG findings of ST segment elevation. The pathophysiology of acute MI is typically related to the sudden occlusion of a coronary artery, most commonly due to the acute rupture of an atherosclerotic plaque followed by thrombus formation. This is known as an acute coronary syndrome. Let's break down each option. While MI can eventually lead to decreased cardiac contractility and heart failure if left untreated, this presentation with sudden onset chest pain and ST segment elevation suggests an acute coronary event rather than chronic heart failure. While diabetes mellitus is a risk factor for atherosclerosis and contributes to the overall risk of MI, it does not directly explain the acute rupture of an atherosclerotic plaque leading to an MI. The combination of a vulnerable vessel due to atherosclerosis and vulnerable blood due to risk factors like diabetes can increase the risk of thrombus in coronary arteries. While ischemia can lead to impaired fatty acid oxidation and intracellular pH reduction, this is not the primary mechanism that explains the patient's acute presentation with severe chest pain, ST segment elevation, and other symptoms. These metabolic changes are more likely to occur during prolonged ischemia. A 60-year-old male presents for an exercise stress test due to a history of intermittent chest discomfort during physical activity. The test follows the Bruce protocol and the patient reaches stage 2 without symptoms. However, during the test, his blood pressure remains unchanged and he develops severe, which is greater than 0.2 millivolt ST segment depression in the precordial leads. Furthermore, the ST segment depression persists for more than 5 minutes after exercise termination. What is the most appropriate interpretation of this test result? A. This test result suggests a false positive finding due to the patient's inability to reach higher stages of the exercise protocol. B. The test result is likely inconclusive and further evaluation such as myocardial perfusion imaging is warranted to assess the extent of ischemia. C. The patient's symptom along with the development of severe ST segment depression during the test indicate a low risk of future adverse events. D. The test result is highly suggestive of severe ischemic heart disease and a high risk of future adverse events given prolonged ST segment depression. Or E. The absence of symptoms during the test suggests a false negative finding and further evaluation is not necessary. Now let's pause here while you answer the question. The correct answer is D. The test results is highly suggestive of severe ischemic heart disease and a high risk of future adverse events given prolonged ST segment depression. During a graded exercise test, there are several key parameters we monitor. One of the primary things we look at is the heart rate and blood pressure. As the exercise intensity increases, it's perfectly normal for the heart rate and blood pressure to rise progressively. This demonstrates that the heart is efficiently pumping oxygen-rich blood to meet the body's demand for increased energy during physical activity. Sometimes we encounter situations where blood pressure fails to rise or even decreases during the test. This is a significant cause for concern. It may indicate that there is insufficient blood flow to the heart, leading to ischemia, which can in turn cause a global dysfunction of the left ventricle. This is a negative prognostic sign. Now let's talk about some specific signs we watch out for during these tests. Firstly, the development of angina is a clear warning sign. If angina occurs especially at a low workload before even completing stage 2 of the Bruce protocol, it raises concerns. This early onset of angina suggests that the heart is struggling to keep up with the demands of exercise, which is a strong indicator of severe ischemic heart disease. But that's not all. We also pay close attention to the electrocardiogram, which records the heart's electrical activity. If the EKG shows severe ST segment depression of more than 0.2 millivolt during the test, or if this depression persists for more than 5 minutes after exercise has ended, it becomes an alarming sign. This kind of ST segment depression is a strong predictor of future adverse events and a high risk of severe heart problems. A 62-year-old male patient with a history of stable ischemic heart disease presents to the cardiology clinic. He has been experiencing recurrent angina despite optimized medical therapy. His coronary anatomy reveals 3-vessel disease, including the proximal left descending coronary artery. The patient's ejection fraction is 45%. His medical history is significant for diabetes mellitus. The patient is considering revascularization options. What is the most appropriate initial method of revascularization for this patient? A. Percutaneous coronary intervention with drug-eluting stents. B. Coronary artery bypass grafting. C. Continue with optimized medical therapy. Or D. Repeat stress testing and follow up in 6 months. Let's pause here while you answer the question. The correct option is B. Coronary artery bypass grafting is the recommended initial method of revascularization for patients with 3-vessel disease, proximal left descending coronary artery involvement, impaired global left ventricular function with ejection fraction less than 50%, and those with diabetes mellitus. This patient fits multiple criteria for CABG, making it the most appropriate choice. Percutaneous coronary intervention with drug-eluting stents may be a suitable option for patients with single or 2-vessel disease, normal left ventricular function, and anatomically suitable lesions. However, in this case, the patient has 3-vessel disease, proximal left descending coronary artery involvement, and impaired left ventricular function, making PCI less optimal as an initial choice. Continuing with optimized medical therapy is essential in the management of ischemic heart disease. But in this patient who experiences recurrent angina despite medical therapy and has specific characteristics, revascularization should be considered. Repeat stress testing and follow-up in 6 months is not the best course of action for a patient with recurrent angina, significant coronary artery disease, and impaired left ventricular function. This approach delays necessary intervention. A 58-year-old male patient with a history of stable angina pectoris is prescribed long-acting nitrates to manage his condition. He has been using sublingual nitroglycerin for acute relief of angina episodes for the past year. Lately, he has experienced increased frequency and severity of angina episodes and seeking alternatives. The patient is concerned about side effects like headache and dizziness. You discuss the use of long-acting nitrates as a potential treatment option and emphasize the importance of individual dose titration to prevent side effects and nitrate tolerance. Which of the following statements is accurate regarding the use of long-acting nitrates for the management of angina? A. Long-acting nitrates are more effective than sublingual nitroglycerin for acute relief of angina. B. Individual dose titration is not necessary when using long-acting nitrates. Or C. To minimize nitrate tolerance, patients should have a minimum of 8 hours each day free of the drug. Now let's pause here while you answer the question. The correct answer is C. To minimize nitrate tolerance, patients should have a minimum of 8 hours each day free of the drug. Long-acting nitrates are primarily used for prevention and not for immediate symptom relief. Individual dose titration of long-acting nitrates is important to prevent side effect. With this thought, I will take your leave until we meet again. If you like this video, please like, share and subscribe to our channel. Read well, revise more, aim high.